Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines are in a listen-only mode. You may submit your questions electronically anytime by using the Q&A pod located to the left of your webinar. You may also download a copy of today's presentation using the resources pod located below the Q&A pod. It is now my pleasure to introduce today's first presenter, AHA moderator, Drew Solo. Sir, you may begin.
Welcome everyone to today's webinar. This is Drew Solo with the American Hospital Association. I'm pleased to be moderating today's event, Cultivating Change in Surgical Services at Nash UNC Health Care. This webinar is brought to you through the generous support of Philips. During this webinar, Nash UNC Health Care and Philips will discuss surgical services assessments at Nash General Hospital and at Day Hospital. The assessment goal was to understand the current state of operations, evaluate existing performance improvement initiatives, and develop implementation for processes and strategies to expand and take initiatives to the next level. The performance improvement initiatives focused on building existing successes with surgical services, key performance indicators, or KPIs. The implementation plan addressed first case on-time starts, case duration accuracy, room turnover time, and avoidable cancellations. The speakers will illustrate the specific steps that drove the creation and optimization of the KPIs. Please note you may submit a question for our speakers in the question and answer box to the left of the presentation at any time. Simply type your question in the box and hit submit. With that, let me briefly introduce today's speakers. Julie Lawler is the Director of Surgical Services at UNC Nash Health Care. Julie's goal in surgical services is to take performance improvement initiatives and bring them to the next level. She has more than 20 years of experience in surgical services and is a member of the Association of Perioperative Registered Nurses, or AORN. Julie has gained great traction with her team and is seen as a dedicated and supportive department leader. One of her primary goals has been to identify and resolve additional concerns with surgical services that were not allowing the optimization of outcomes that she desired for the department. The outcomes desired included accurate case scheduling durations, increased on-time start percentages, and a reduction in avoidable cancellations. Our second presenter, Peggy Clifton, is the Senior Manager of Healthcare Transformation Services at Philips. Peggy is focused on performance improvement and leading surgical services projects that deliver impactful changes to a client key performance indicators. She is also a member of the Association of Perioperative Registered Nurses and has partnered with clients to gain significant improvements in their patient flow across the surgical continuum. Her clinical experience spans surgical services, adults and pediatric intensive care, as well as nursing administration. She has served as the Director of Surgical Services for several large health systems as well. It is now my pleasure to turn the floor over to Peggy, who will begin our presentation.
Thank you very much, and good afternoon, everyone. We look forward to sharing how Nash UNC Health Care and Philips partnered on this performance improvement journey. Julie, are you there?
Hi, everyone. This is Julie Lawler, and I can't thank you enough for taking some time out of your day so that we could share our story in how I initially started improving the performance here at Nash, but then chose to partner with Philips to take the performance to the next level.
So Philips is uniquely positioned to be that trusted partner, and with an ongoing engagement, we do really value a shared purpose. We believe in collaboration and continuous improvement, effectively deploying change, and being able to achieve annual and longer-term performance objectives. With shared purpose and risk, we can achieve our mutual goals because we know that our success depends on our client's success as well. We listen to you, the client, and that's what I really strived for when I was working with Julie at Nash, to uncover deep insights into the specific challenges that she was facing, and then support her with the actionable solutions that would help accomplish her goals that she had for her department and her patients. Together we did set those shared goals and delivered on quality and efficiency and cost. So we understand your issue and challenges. Historically, surgical services is the hospital's greatest cost and revenue source, and I know everyone on the line is well aware of that. They're responsible for approximately 60 to 65% of the hospital profitability. So when you have issues within the department, you experience the financial impact rather quickly. And at Philips, we like to partner with you to achieve clinical excellence and operational efficiency, which obviously will result in improvement that you'll see in finances and quality with your patient care. We firmly believe that we optimize existing investments that your organization may already have. Like one of the issues or concerns I really focused on with Julie was their optimization of their existing information technology. That was very important to me because they had already made a very large investment, and I really wanted to help them see what functionality needs were maybe needed to be flipped on or tailored to really help within their organization. You know, we try to uncover everything we can to make sure that you're fully functioning. So we do really try to understand your issues and challenges and tailor the approach to your organization. So with that in mind, we do view healthcare seamlessly, and while I say we tailor the approach, we do look across time and settings and people and data, and we focus on the big picture as well. And as a result, you know, we know that's something that you don't jump into 100%. A partnership like this has to grow. We start with the assessment and really trying to understand your existing baseline, what your concerns are. We look at the data analytics, and we provide you with proof points and what we think could be ways that we could help you deliver quick value as well as longer-term value. And really it's focusing on taking away your worries and providing you with predictability instead. Because in this day and age, we should all be able to measure and monitor and track and trend what we really want to focus on to be able to improve performance. And the real big value comes when we create those real integrated solutions. We like to help with managing the surgical patient across the continuum, and sometimes that does require us to look over into other parts of the hospital, and we do delve into that as well. So I think what I really want to say is we're in this for the long run, and we have many health system customers who trust us. So we really enjoy optimizing for today and preparing for the future with our clients. So this next slide with industry benchmarks is a snapshot of key surgical services benchmarks. And as I mentioned, this is just a snapshot. I wanted to be able to illustrate where to start, and these are high level. I sourced them from AORN and advisory board. I listened to, when I was working with Julie, I listened to her concerns. I looked at a gap analysis, and then together we built agreed upon solutions for the performance that she wanted to optimize to be able to take her initiatives to the next level. There are multiple benchmarks that we could look at within an operating room, which I'm sure you are all aware of, and this is just the initial snapshot. So about Philips Healthcare Transformation Services, I really wanted to take just a moment to let folks know that while we are a technology company, we do have a strong consulting practice, and we do deliver solutions-oriented and people-focused PI projects. And I myself have been a nurse for 31 years and in consulting for 16 years. And as was mentioned earlier, I've served as a director of surgical services in my past. And I really, really like our style at Philips. We focus on tailoring the approach with sustainable results, because all of us, as you see in the middle of the slide, 100% of us have been in folks like Julie's shoes. I mean, I've been a director. Our other leads have led in leadership roles within their organizations. So we would like to introduce you to Nash. This is a high-level timeline of milestones for Nash. Nash started in the early 70s as the first all-private room hospital in North Carolina. Nash UNC Health Care is located in Rocky Mount, North Carolina, which is roughly halfway between New York and Miami off Interstate 95, for those of you that may be local or on the East Coast.
And also, Nash really has evolved over the years and provides many services. We joined UNC Health Care in 2014. UNC Health Care is a not-for-profit integrated health system owned by the County of Nash. And so Nash UNC is a managed affiliate of the UNC based in Chapel Hill, North Carolina. UNC Health Care has 11 affiliate hospitals and hospital systems across the state. It includes a provider network, clinical programs from the University of North Carolina School of Medicine. And I'm very proud to see this slide where it shows where we've come from the 70s to where we are now. Because it is a county-owned hospital, the money has to be recycled, so to speak, so that we are continually using it to upgrade our hospital and the services that we provide.
So Nash Day opened in 1984 as a subunit of the hospital and as a freestanding outpatient surgery center. They have 5 operating rooms which provide ophthalmology, orthopedic, and gynecological surgeries.
And then Nash General, and its main purpose when it was first built was really with the input of inpatient surgeries. And it has 8 OR rooms, and it provides general surgery, cystoscopy, bariatric surgery, orthopedics, gynecology, and neurovascular. We experienced what everyone else is experiencing in the industry, where a lot of your surgeons are getting to the retirement age, and not to mention the staff, because your average age of an RN nurse is probably in the high 40s. So it doesn't take a lot of guesswork that, after another 20 years or so, you're going to be ready to retire. And so we found ourselves needing that reset button. So a lot of our processes needed to be revamped and revisited.
So how did we start that? We looked at leading benchmarks, and we compare the client data definition and the industry definition to determine where we are with the baseline and make sure that, Julie and I are having the same conversations. When we talk about first case on time starts, we're talking about the same definition. Is there a grace period? Is there not a grace period? What's the goal? And that's very important also for the data analytics person that is on my team, who is also working with me on taking that raw case detail and looking at what's going on at the same time while we're working on site.
And Peggy brought up a great point where we had to agree upon what were the definitions. And so something that was a little different for Nash, apart from the other UNC affiliates, is that they would allow a 5-minute buffer and still call it on time for the first case. So if it was scheduled for 7:30 and they were in the room by 7:35, it was still counted on time. I decided that I really wanted to push Nash a little harder and did not allow a buffer. So 7:31 was late. And I think that was a really good decision. I think sometimes a buffer allows you a little leeway, and you really, if you get an inch, you can take a mile. So that was my reasoning behind that.
So after the assessment was complete, I worked with Julie, and I had an idea of key findings and recommendations that would address the improvements that I thought I heard she was saying. So what we did was sit down and have a conversation about, what are the areas that we want to select for this particular PI project.
And so I'll have to say that it was a really great opportunity to be able to sit down with someone that actually knew what it was like to be a director of surgical services, and then be able to really talk in the same language. What did Nash really want to focus on? And then Peggy was able to match that to industry benchmarks, and then we tailored it to Nash. So there was a lot of flexibility in being able to choose your own key performance indicators and what the benchmark was going to be, and so then she helped me to be able to achieve that.
So as Julie mentioned, she began performance improvement initiatives and had gained some really good outcomes. And for this particular project, she was requesting a laser-like focus for 12 weeks on key performance indicators, report generation, case duration scheduling, in order to, to close any further gaps that she was having in performance. Because at the end of the day, she already has a full-time job, and PI can additionally be a full-time job. So design and implementations that we came up with focused on efficient patient flow through the continuum, and greater transparencies were created regarding the data, the definitions, the calculations, surgical scheduling, what we were doing with doctor preference cards, and overall the information technology system within surgical services.
So our goal was really to remain budget neutral and optimize our existing functionality within our IT system. And in order to do this, we also needed to take a look at our workflow processes and determine where there were inefficiencies and go after the remaining potential improvements. I base my leadership style on relationships, and I really do feel like I have a good relationship with my leaders. And I think that the first part of the success actually is being in tune with your staff and your frontline leaders so that you can help them get engaged. And so what I did is we assigned staff into 4 separate work groups to focus on improvements. And so that was part of the buy-in on the staff's part, because we all know if you do not get some sort of buy-in and it is a forced process, it probably will do well for a little while, but then 6 months down the road you probably are having to start over. So even in phase 1, we focused on operational performance for first case on-time starts, turnover times, cancellations and delays, and doctor preference card redesign.
So how do we bring everyone together? And I will say, as as the consultant, I'm usually looking for strong engagement from either my director of surgical services or the chair of anesthesia or the chair of surgery, and if I get lucky, maybe all three. But definitely a strong relationship in one of those three roles is very much needed to drive any PI forward with a client, and definitely I can honestly say there were very good relationships there at Nash, which I think contributed immensely to our success. But we also had to look at the roles within surgical services because everybody is really good at what they do, but sometimes don't have time to think about, what happens before I get the patient or after the patient leaves me. So our goal was to help them pause and see the entire surgical continuum and take a longer look to see where things could be better for the patient who is traveling through this continuum.
And I believe that one way that we accomplished bringing everyone together was communication and making sure that everyone knew up front what was the goal of the project. There's a lot of unknowns when a consulting group comes in. It could be crazy thoughts of, okay, they're doing a job reduction. So we were very purposeful in our communication and being transparent about that. And then giving a lot of appreciation. Staff will almost do anything that you ask them if they feel appreciated. And I've found that over and over again. And their importance to what they give to the patient and connecting that to the project, I think, was really key.
So what did we do to get ready? Julie and I had some pre-work to do prior to me being on site. And also, I just want to take a moment here to stress that this was an expedited timeline. It was 12 weeks. If there's more involvement with PI within a surgical services department or a larger scope, you want to look at multiple things, I've been involved in projects that can take anywhere from 24 to 36 weeks as well. So it just depends on what you're actually looking at. Each week of the 12-week project, we had a journal, I keep saying that, journal. We had a journal article which was featured to illustrate the importance of a specific element of the PI that Julie and I wanted to focus on with the group. And we tried to make sure that we were appreciating everyone's role. So we focused on data collection, KPIs, operational efficiencies. We pulled things from anesthesia journals, surgery journals. We looked at every part of the process to bring everyone together.
And I was really excited to see that this was part of Peggy's goal and part of the project was to bring in articles, because we had just actually started having our registered nurses be required to participate in a evidence-based journal annually. So this was just right on the heels of that, and it really drove it home that it's really important to search out your articles of the professional organizations to drive some of your decisions. And some of that was the American College of Surgeons about the surgeon turnaround time. I don't think that there's a surgeon out there that isn't concerned about their time, meaning incision cut to close. And anything outside of that, they, in their minds, determine that as downtime. Health IT outcomes addressing key performance indicators. AORN about operational efficiency. And these articles were made available for the entire department, just not the folks that were involved involved with the work group. So, it really tried to pull everybody in and not exclude anyone.
So what did we actually do? This is the high-level project summary, and it shows the people, process, technology, and the KPIs that we were working with across the surgical continuum and the outcomes that we were striving for and did get to. What we addressed a lot of things very specific to Nash, as Julie mentioned, and we built our goals and project objectives and tools in order to accomplish their specific goals that they had in mind. And so I think that's really the big thing I wanted to stress. It's tailored. This work needs to be tailored to each client's problem statement. As a consultant, I feel very strongly about that.
And also, we were able to achieve improved processes and consensus-driven sustainable change. I think that really is one of the big parts is if you're doing all that hard work, make it be in a way that it can last 3-6 months down the road. So I think careful planning and communication in the very, very beginning is super important, and you're pulling everybody along at the same time. Otherwise, it could just really drop off after the consultant is gone. But Peggy did such a wonderful job to assist me to be able to get that sustainable change, and I really appreciate that.
So with the expedited project timeline, we just wanted to illustrate exactly how quickly we were moving during this and still highlight our successes. So we had 12 weeks, as we've mentioned, to focus on improvements, and our measurement period for success, we had to set, which weeks are we really going to have as this is where we look, did we make a difference in our KPIs, and those were weeks 11 and 12. So we had pre-work, as we mentioned, that we did prior to me being on site, and with week 1, the work group started, which was amazing because we wasted no time once we were all together. So we had current state workflow meetings, and we were looking at calculations within the electronic system. By week 2, we were already looking at the KPIs and, of course, getting the staff up to speed with the journal articles and finalizing current state. And also, by week 3, we were getting into what does that future state look like and how do we eliminate those barriers to best practices. We know where we want to go. What do we need to remove? What's keeping us from getting there? With week 4, we finalized the future state workflows, and week 5, we started digging into policies and processes for looking at preference cards. There was always something we were working on, and I think we were able to implement very early on a lot of these initiatives because we knew we had a short timeline, and that's how we were able to gain the great outcomes that we did.
Okay. During the 12 weeks, and I'll have to ditto what Peggy just said, that was a fast 12 weeks. All our heads were spinning. It was a fast project, and there was lots to do. But what we did is we had weekly data analytics completed specifically for first case on time starts, turnover time, and case duration accuracy. We were then able to compare this to our data points in order to determine any gaps in data integrity. So you always have your hospital's IT program, and then you have an outside consultant looking at that same data, is there differences in the data? Because that would be really important to determine if they're going to continue to help us succeed. We've got to be on the same page. So Peggy left off on week 6. So week 7, I thought this was really exciting. Was we revisited parallel processing by role. And I don't know if there's anybody out there that has ever gotten into the this is how we do it kind of mode. And, you know, everyone has their job and you do it one by one by one. But we really looked at, okay, what kind of work could be happening at the same time, and we standardized that process and roles for case cancellations and rolled out a monthly newsletter. And I really thought that was a nice addition because it went to surgeons, but it also went to the office managers, and so they were kept apprised too. Week 8, chart completion changed from 24 to 48 hours prior to surgery. Okay, so this one was big. So what we were doing is we were only getting one day, 24 hours, our charts for the next day complete with H&P orders, and we were really just chasing our tail. So we went to SSG, which is Surgical Services Governance, and we asked, will you support us to go to 48 hours so it gives us time to see what things are left off. Maybe it was a cardiac clearance, whatever it was, and so it wasn't just the day before. So that was big. Week 9, we finalized the future state workflows, and that went to Surgical Services Governance for approval. Week 10, so the data integrity issues were resolved. Adjusted case durations based on historical data within operating room information systems. So we had a system where you had to do, and we'll just use this for an example, 10 of those same cases. So you'd have to do 10 laparoscopic cholecystectomies before the system would average a time for you. And so we did some requests to improve that so it wouldn't take that many times to get an average. And then week 11 and 12, we continued to measure and monitor and make sure that the improvements that we had put in place were continuing. So it was a lot of simultaneous work on everyone's part.
So what you'll see now on this slide and the following slide is a snapshot from this is Nash General, and then Nash Day will be on the next slide. We looked at the data points for the 2 separate locations, and we wanted the staff to be able to appreciate their efforts for the total 12 weeks, as well as the best week of the 12-week project, because, as we've mentioned, 12 weeks is rather expedited. So that's why we set it up this way. With general surgery and day surgery, one of our biggest successes was reducing overall avoidable cancellations. And that's where really moving from a 24-hour to a 48-hour chart completion really made a difference. Because you can catch, like I said, maybe a cardiac clearance or a lab that was not going to be able to be corrected in one additional day, so then you could go ahead and start optimizing that patient and reschedule them.
we were very focused on getting cases on the schedule and didn't want to say no to anyone. So that was the mentality that you need to fill every space in your operating room, irregardless of is the chart complete, has the patient met all their criteria. It was a fill the rooms up. So we had to become really proactive and review and require documentation well ahead of time so that we wouldn't have those avoidable cancellations. And that took some work because physicians don't like to change.
So for Nash Day, they already had great turnover times, so we focused on the scheduling and on-time start.
And in Nash Days, real improvement was case duration accuracy. And you could almost do a webinar on just case duration accuracy. But what we were finding is that it was a little complex depending on what type of case with the CPT code that the surgeon was using, and it may pull up one of 3 different procedures. And so we really, before Peggy came to work with us, we're getting 3 different options, and so our case duration accuracy wasn't there. And so we've really done a lot of work around that. Our goal is 60% case duration accuracy, and we weren't anywhere close to that as the project started, but we really made headway.
So going back to what we mentioned earlier about the staff work groups, we wanted to share how we set the project up for success. The 4 work groups had a very tight focus across people, process, technology, and looking at improving on-time starts, reducing turnover, reducing avoidable delays and cancellations, and reviewing and updating the doctor preference cards.
And so then you're faced with, well, what staff do you select to put in these groups? And so the angle that we went was, let's get some that are really energized about the project, and maybe a naysayer. Every group probably has one that's really just not bought in to this improvement, and then try to get them on board, because if you can get that person on board, you've made it. And so one of the things that we tried to emulate or use as an example when we were looking at turnover in that work group is we tried to learn from Nash Day surgery, because they were already really efficient at their turnover time.
So one of the ways we wanted to share this with the staff, we had to be mindful of, we were having work groups, so staff had to relieve staff to go to these meetings that they were not getting to participate in, and we wanted them all to appreciate the work that had been done. So we put together a gallery walk or a poster presentation where everyone had the opportunity to see what occurred in each of these work groups, who the team members were, the progress to date, and what impact that had for the staff. What should they be watching out for? What am I going to see different in my day today within surgical services?
And as Peggy mentioned, the staff that had to, stay in the operating room, because, someone had to continue to take care of patients while the groups met, it was really important for them to see all the hard work that had gone into these work groups, and that they were a part of that by allowing their teammate to participate. And you also have to make sure that you are explaining that the work and this project, the goal, or at least one of the goals, is to make their day easier, because we're trying to create some efficiencies and some lean methodology. So you really have to explain all the steps as you go along so that no one's left out and everyone is included. So the on-time...
So, Julie.
Oh,
Oh,
yes.
yep. I'm sorry. Go ahead. I was just going to say maybe we could quickly go through these next 4 slides so we have time to get through the rest of them for the group.
Okay, I'll go quick.
Okay.
So the on-time start work group really just focused on what is our baseline, what's our barriers, and how are we going to attack getting our on-time start to be where we want it to be, which is 80%. The turnover time work group. So I think one thing that was really important in this one is that we had one of the ancillary support personnel that helps turnover rooms to be involved in this group. So anytime that you have a group that is going to affect a specific role, you need to make sure to include them. And they're just like all the other work groups, you identify the barriers, and then you start creating what do we need to move forward. And also parallel processing was huge. Cancellations and delays work group. So that looked at what is our current way of documenting and preventing avoidable cancellations. And so that really was just a rework of whose responsibility it is so that you don't have multiple hands touching it and they're all doing something different. Doctor preference cards. For those out there that know doctor preference cards, that's a big challenge to keep those updated. And so this one was probably our most daunting to improve. And we use Epic here at Nash, and the preference card drives so many different things: the CPT code, the case duration, supply, cost, and efficiency.
So we've mentioned regarding people influence, the great relationship Julie has with her staff and her leadership style is just amazing. It's one of the strongest pulls for the work that we were able to get done within this department. And I can't stress that enough. Having a strong leader is key in getting any PI work done within a department.
And as I said, I think relationships are very important, and I wanted the staff to be able to share their poster presentations, and so all staff did review all those, and it's really important to pull staff together. That's the important thing, is to include everyone.
So I think what we really need to share with you is how did we actually get this done? And a lot of that revolved around the standardized work documents, because you can always talk about putting something into place, but until you spell it out and everyone understands their role, you have to educate others in order to get adherence to what you want to do moving forward.
And the monthly newsletter was a really great way to communicate with surgeons and their offices, because so many times I believe that you're communicating with the surgeons, but the office managers and the office staff, they're not really getting that communication. And so they actually expressed gratitude for that letter.
So for process improvements, the doctor preference card policy is simple, yet makes a clear statement of what is expected moving forward. And I really think the surgeons like being asked about their supplies, and we're pleased with ongoing updates and being included in the PI.
And a recent change to our electronic functionality within our system is it actually shares with the physician their cost per procedure, and it actually lists cost per supply item. And that has been a huge engagement for surgeons because several will come to me and ask, hey, why? Why am I more expensive than the other? They're very competitive. So I think that that was an awesome addition that is driving pref card review, which is really important.
So talking about the doctor preference card policy, it's easy to put in place, here's what we're going to do, here's the policy, now let's follow it. But we also took it a step further and created a checklist or a tool for those service line leads to use because we wanted the staff and the surgeons to have progress on the accuracy of the cards and how that was moving along.
And the checklist was really very useful because it made us be consistent. And so that's another thing about, I think, sustainability is consistency.
And Julie mentioned earlier that surgeons are always very interested in their turnover time because when they're not actually operating, they think that's downtime, even though there are many things that need to go on for the patient. So during the PI project, we focused on surgeon turnaround times. And, the question is always, what does that look like? Where should it be? This is something the organization has to review from the political, financial, and really cost implications because you get into slipping rooms or overlapping cases. So it's really an organizational decision.
And we were able to accommodate a few surgeons prior to COVID-19 as we had rooms available for flipping. Our general OR gained about an average of 4 minutes with the flip rooms, and Nash Day, they really didn't gain anything because they were already so efficient at 23 minutes turnover, so I didn't really see any improvement there.
So as far as technology enhancements, my goal was to partner with Julie and get what she needed for her department, and we decided that would involve the larger UNC group to build custom reports that would acknowledge the set targets for Nash Day and Nash General because, as we all know, goals are often different across hospital systems and they're perfectly acceptable within the parameters of best practice. So we looked at what does that need to, what do we need to change to tailor it to Nash Day and General for the KPIs we were looking at.
And so we had an operating room information system upgrade and needed to fine-tune our functionality to match our workflow. So we, not too long, had switched over to Epic, and so that really had different workflows, and so we really needed to match that IT to our workflow. So we really needed a reset on that.
And as we mentioned earlier, in order to determine where the gaps were within the data, we were trying to work our way through the system upgrade and were we on the same page, consultant and client. My Philips data analyst was working with case detail and the definitions and the calculations as we mentioned. And we were trying to find any inconsistencies around scheduling of cases and times booked.
And so we were able to improve chart completion prior to the day of surgery and change the incomplete chart reasons one at a time to improve our accuracy. And so our larger focus was obtaining surgeon orders and H&P.
So this presentation was not specifically about COVID-19, but we still wanted to touch base on how COVID-19 impacted surgical services and, of course, changed the landscape within which we all work. So after the project and prior to COVID-19, performance was sustainable and there were a lot of successes. But since COVID-19, there have been changes that have required some retweaking, and I'll let Julie just dive right into the discussion on what those are.
So as of March 20th, all of our surgeries, with the exception of the urgent and emergent classifications, were ceased. And this included Nash Day, Nash General, and our endoscopy department. In addition, our Nash Day operating room had to be totally evacuated, moved to Nash General, and now it has been refitted as a COVID unit. So needless to say, that's a little challenging to, in one day, evacuate an OR and achieve some organization when you relocate. Our biggest challenge is space to store the equipment, and really not enough rooms to accommodate additional outpatients that were at Nash Day and endoscopy. And communication to the masses, that's really challenging. But I think the wins are resetting our brains, ability to think fast on your feet, flexible, adaptable, and willingness to let go of those sacred cows that we all like to hang on to. Building new relationships with staff that you might not have worked elbow to elbow with, and really coping mechanisms and being kind to yourself and others. And I'd just like to briefly say that when I was approached for this project and was told that I was going to have a consulting group come in, my first reaction was, oh boy, I've got another consulting group that's going to come in and try to fix everything. And the moment I met Peggy, that all went out the door, and I have thoroughly enjoyed learning from her, the benefit of how Phillips sets things up that your partner will be an equal with knowledge that you can speak the same language. So it is beyond this project that I have benefited, and I truly appreciate that. Back to you, Peggy.
Hey, this is all we have for you now. We will send it back to Drew.
Great. Thank you, Julie and Peggy, for your presentation. We will now begin the question and answer portion of today's event. As a reminder, you may submit a question for our speakers in the question and answer box to the left of the presentation. Simply type your question in the box and hit submit. Our speakers will answer as many questions as possible in the time remaining. Questions that are unable to be answered in our allotted time will be shared with the speakers for follow-up offline. Peggy is also available via email at any time. So, first question, and I think this is probably more for Julie. Julie, what charting system do you use?
We use Epic, and it's Epic at UNC, so I know every, the Epic has its own versions, and so it's Epic at UNC.
Perfect. Great. Thank you for clarifying. Julie, probably another question for you. Peggy, feel free to chime in as well. Julie, was your surgeon participation difficult?
So yes, at first, you always try to get a champion first, and then you try to pull everybody in. So what was really nice is that the surgeon champion and my executive sponsor from administration were very key in communicating through surgical services governance. And I think that that's a really good platform if any of the other participants have that group to vet things through, because that is where we really got their buy-in and participation, so that there could be good communication how it's going to benefit them, because that's really what they want to know.
Great. Another question for you, and I think you did touch on this, but could you elaborate on how you continued progress after the project was over?
So what we did is we kept using the tools that Peggy and the groups designed. So the doctor preference card review checklist, the standard workflow. So I think it was that everything was in black and white. It wasn't just the spoken word. And so you continue to reflect on those. And really the trick, I think, is to just never let up. You always have to be talking about it and measuring it and sharing those measurements. If you veer 1 week away from it, then you're going to lose your momentum. You always have to be present and talking about it.
Great. Another question, can you elaborate a little bit further on your administrative support? Did you have administrative support right away? Can you give us any examples of how you won that over, or share any more details there?
No, I had administration support right away. My executive administration was the chief nursing officer and the chief operational officer. And so from the very beginning, I had all the administration support that I needed. So without that, I think you would not be successful.
Great. Okay. And another question for you. What key performance indicators do you focus on with performance improvement projects?
So really, I think all operating rooms tend to look at the same metrics. And so first case on time starts, to follow cases to start on time, cancellations, turnover time, and really case duration accuracy was a big one for us as we were challenged with how Epic was attaching that to CPT codes. So, if your case duration is off, then your day's plan for this surgical arena is off. So that's a big one.
And Julie, if I might add something at this point, I think for KPIs, it really is, the success of the whole department depends on having that governance model, which Julie does have in place, and then the folks having different pieces and parts of that, metrics to look at. So, someone needs to be watching block time utilization, inventory accuracy, the satisfaction scores, and then you've got everything that Julie just mentioned with the on-time starts and looking at the actual operational performance and the turnover times and cancellations and room readiness. So I think there are lots of KPIs we didn't talk about because that wasn't our focus in this specific 12-week, laser-like look, but there are many that can be measured and monitored and tracked and trend for performance.
Okay, great. Well, that concludes the time we have available for questions. In the next few days, all attendees will receive an email that will include a link to the archived webinar session. Thank you to our audience for joining us, and thank you, Julie Lawler and Peggy Clifton, for your presentation. Thank you to our sponsor, Philips. Thanks again for joining. This concludes today's program, and have a wonderful afternoon.